this activity is presented free of commercial support. And our first speaker, did I get all the disclosures? Are we good? Okay. And I'm going to go right to that one, and then Mark. There we go. Okay. So our first speaker is Mr. Marc Bennett. Marc is President and Chief Executive Officer at HealthInsight, a private nonprofit healthcare improvement company. HealthInsight has offices in Utah, Nevada, and New Mexico, where we hold Medicare, QIO, and Quality Improvement Organization contracts for all 3 states. You're going to hear a lot about HealthInsight in the next 2 days and the work we do in the REC and the Beacon programs throughout this track. And I will leave the provision of additional information about HealthInsight to Marc, the rest of the speakers you're going to hear during this track. I will say HealthInsight is a recognized leader in transparency and public reporting, in HIT initiatives, payment reform efforts, change management, research, and application. So I think there's something here for everybody, even if your background is not healthcare. And we're all patients, right? We've also led numerous innovative efforts in the CMS, that's Medicare, Medicaid, QIO Beneficiary Protection Program. Just so you're aware, Mr. Bennett is a past president and board chair of the American Health Quality Association, the trade association for QIOs. Additionally, Mr. Bennett currently serves on the Quality Alliance Steering Committee, a body that coordinates federal and private sector healthcare quality initiatives in the United States. Mr. Bennett is a frequent contributor to national policy forums, NHIT, Health Information Exchange, and Quality Improvement. He's also a member of the National Advisory Board for the Center for Healthcare Quality and Payment Reform, and he serves as a board member for the Network for Regional Health Improvement. Locally, Marc currently serves as the board chair of the Utah Health Information Network, and he serves on the advisory board for the Utah Health Insurance Exchange. Marc obtained both his bachelor's and master's degrees from BYU. Marc?
Thank you, Heidi.
Clicker.
And is there a place I'm supposed to point the clicker at? Just anywhere out there seems to work? Okay. All right. So thank you for letting me spend a few minutes with you today. I'm going to be talking to you a little bit about the federal health reform agenda and the implications for the work we're doing in Utah, particularly related to the Beacon Project, which is the theme of the series of presentations that you'll hear in this track. And so I'm really not going to describe Beacon to you. That's going to happen as you go forward, but I'm going to sort of lay some groundwork for that. And then following me, Patty Connors is going to lay some groundwork about what's going on in Utah in a little more detail. So I'd like this to feel interactive. If you want to ask a question, no reason to wait till the end. I think we have a little time cushion in there, so feel free to chime in with any questions as we go forward. I want to start by giving you just a little bit of background on HealthInsight. So as Heidi mentioned, HealthInsight is a nonprofit corporation. We've been operating in the state of Utah for 35 years, 40 years now, I guess. And our mission is to drive change in our community in a positive direction towards improvement. We've been doing a lot of work recently, in recent years, around what we call ENDS policies. These are our focuses for changing the healthcare system in a way that will make it more effective. So that center column in the graphic there includes engaging the public or the patients in their own care, improving health, producing high quality processes and outcomes as a system, using resources responsibly, and making the system more transparent. We view ourselves as a connector of people. We bring people together. We try to build will for change at the community level. We try to bring programs together in order to eliminate confusion, minimize that, and make the system work more holistically. And then we work to identify gaps and design strategies to fill those. We've done a lot of projects over time as an organization, and we tend to be funded we go out and seek funding for projects one at a time from different sources. significantly funded by the federal government over the years. Quality Improvement Organization has been our historic roots, and that's an ongoing program funded by the Centers for Medicare and Medicaid Services to try to promote care improvement at the community level in states across the nation. We have a funding to support small physician practices in adopting and effectively using health information technology and electronic health records in their practices. We have the Beacon Community Program that we're focused on here, which is in some sense is an effort to, culminating effort to try to pull together all of those pieces to really dramatically transform care using HIT and care improvement strategies to change our system and show what's possible in an advanced HIT environment. We've been instrumental in the development of health information exchange capability in our communities so that data about care and involving a given patient can flow seamlessly from one provider to the next and support better decision making and more engagement in the care process. And as another example, we now have funding in one of our states to work in nursing homes in a very direct way involved in care management, supplementing the care process with the aim of reducing hospitalization by as much as 50% out of those settings of care. This diagram describes what we see as the key relationships that matter if we're going to try to transform a system. Healthcare is a very complex undertaking, and regardless of what your business is, it's probably, you can see parallels in your world for the complexity of difficult challenges. And healthcare has proven very resistant to substantive change for a long time, and we're going to talk about why that is as we go forward. But we really believe all of the features of this diagram are necessary to change our healthcare system. We need to have engaged consumers. We need to have sharing of clinical data. We need to have information technology resources brought to bear. We need to have transparency. We need to have workflow redesign. And all of that has to happen in a context of payment reform. A substantive part of this presentation, I'm going to talk to you about the federal agenda around payment reform and why it's so critical to our system's current performance and why we behave the way we do today. So to get started, I want to just start with what's the environment we're working in? Why do we even need to talk about redesigning our healthcare? If you're not in the healthcare industry, I believe that it's a changing space, but for a lot of people who are unfamiliar with that, our tendency is to perceive we have a pretty good healthcare system. And in some respects, we do have a pretty good healthcare system. We have the best in the world in some metrics. There are a lot of metrics where we're far from the best in the world, and regardless of how good we are in relation to the world, what I want to present to you is a picture of why what we have is entirely unsustainable in the American healthcare environment. So I want to talk to you about variation in performance. This graph is from the Commonwealth Fund, scorecard on local health system performance. And you can see the American system is all over the map in a literal sense here, but in a general sense, we're far different from some parts of the country and other in most respects. So in this graphic I picked because it's generally a true picture of our healthcare system performance. That is, across any metric you look at, the strongest performance, so Utah tends to be near the top in general, but the strongest performance generally are in the upper Midwest, and the worst performance is generally in the Southeast. That's a generalizable statement across a broad variety of metrics. The biggest problem for us is cost. Now, as a quality improvement person, I'm hesitant to say that. I believe cost is a variable in our system. I think we could pay more than most if we were getting more than most. But if you look at the American healthcare system from this standpoint, it's the one that has to drive every other variable in the equation because of how dangerous we are in that environment. Medicare and Medicaid, these are the two large federally funded programs. Medicare is the program to provide health care to the elderly. All of us will be likely participants in Medicare at some point. Medicaid is the program that provides care for poor, disadvantaged, disabled, others who are in need of additional help beyond what the healthcare system, the private healthcare system generally provides. Medicaid is typically funded in a formula that's partially state money, partially federal money, and Medicare is funded, in theory at least, by our premiums that we pay into the system over time. In the future, as you think about the future drivers of the overall picture of federal spending, Medicaid and Medicare are the largest by far. They outweigh the interest on the debt, they outweigh Social Security, they outweigh and dwarf any other activities. Up here you can see defense spending is the orange line up there. We think of defense as a big line in our system. In relation to healthcare spending, it's not close, and in the future, with that's going to change even worse. The environment is making it so that business competitiveness is affected in substantial ways by the expenditures on healthcare. If you look at this is a look at countries across the line, total expenditures on healthcare. This is where the U.S. ranks in relation to other developed countries across the world, how much we spend on healthcare. And a lot of that cost is being borne by workers and by businesses in our system. So currently, employer contributions in the last decade have doubled, and employee contributions, the individuals' contributions that we make to our healthcare system because of the changing environment, have tripled in the last decade. And that's a trend that simply can't continue if we want to succeed. If you look at this is a graph that's meant to describe how much of the income gains for individual workers are tied up now in the increasing cost of healthcare. It's partly related to that phenomenon of more and more of the costs of healthcare being shifted to individual workers. And in general, that shows the difference. The blue line is the average total compensation increase over time. We're right about here now on this line, but going out over time, you can see expectation of net of health insurance about flat, but because of rising health insurance costs, if they continue on the path currently, we'd be talking about fairly dramatic increases in those costs, which would produce very limited real income gains for individuals. This is a map that I think is telling about the environment we're working in. We'll come back to the principle here, but this map shows from 1994 to 2008 the percentage of the U.S. population that would be classified as obese. And in that 14-year period, we went from a map that had our most obese states having between 15 and 19% of the population obese, to the map in 2008 where we have some states over 30% and the majority of states in the 25 to 9% obesity range. The implications of that particular graph have to do with the prevalence of disease in an obese population, and diabetes is one of the big drivers of cost in our healthcare system. You can see the rapid rise in diagnosed cases of diabetes and projection of that to continue. That will further drive cost in the healthcare system. So what we want to do is we want to create a healthcare system that can reduce cost by improving care. That's our goal. That's what we believe is possible. That's what we believe actually is the only way as a nation that we can solve this problem. So, and there's some who say, can that actually be done? Isn't this a trade-off? Either you have higher costs or you have higher quality or better improvement. We think that's not true. There's lots of ways you can do that. So if we stay healthy, we avoid health conditions, so prevention and wellness is a driver of that. If we are able to avoid hospitalizations and stay and manage care better at the chronic level, then we can avoid costs in the system and make care out better for people who avoid those illnesses or the complications of those illnesses. And when we do end up in acute care settings or in high cost settings, there's lots we can still do to produce more successful outcomes, reducing complications, infections, readmissions, other costs of that system. All of those things are better outcomes and higher quality, and they're all dramatic cost savers. So one last sort of preamble to the discussion about healthcare reform in the federal level is understanding the scale of the opportunity. So this graphic shows from the Agency for Healthcare Research and Quality an assessment that between 5 and 17% of all hospital admissions are preventable. And in Medicare, has the highest percentage of that, which is, again, all federally funded. This graphic from Milliman shows that there are more than 1 million preventable errors or adverse events in our healthcare system annually, producing billions of potential savings if we could produce the improvement that would eliminate those. And then on the cost side, there's a dramatic variation between 5 and 10-fold differences between low and high-priced providers in any healthcare system, and little difference in quality. There's differences in quality, but they don't track with differences in price or differences in cost. So this graphic further illustrates that $8,000 variation in the cost of joint implants, just the joint itself, across California hospitals. And there are many other savings opportunities. For today's presentation, I won't really dwell on those, but the numbers add up. The best estimates, I think, are between 1/3 and 50% of our healthcare system costs are waste in the analyses that have been done by researchers kind of repeatedly over the years. So let's talk for a minute about healthcare reform and the implications. Really, when you look at the ACA, which is the Affordable Care Act, the federal reform agenda, sometimes called Obamacare, or the Patient Protection and Affordable Care Act, PPACA is the official name that it was passed under. But it really has 3 major components to drive change in the system. And I've chosen this gear diagram intentionally because I'm introducing my own bias into the system. The one that really matters is redesign of the delivery system. All the other ones are important, and they're necessary to create that redesign that we're looking for. But we need to start with this one. We need to end with this one of redesign of the delivery system, or we won't actually get anywhere. Now, my bias reveals sort of the place I have more expertise, so I'm going to just preface my comments here to say this is not a space where I would consider myself by any stretch an insurance expert. I've never worked in a health plan. You'll probably get much more knowledge and expertise from Patty, our next presenter, about how that marketplace works now and how it's designed to work in the future. But it's an important part of understanding what the federal government plan is in implementing the law passed by Congress a few years ago. And there are steps in this. They're trying to address is we have an insurance problem in America. And this is the part of the law that gets all the attention, all the good and bad press, and depending on who you listen to, it's either really good or it's going to destroy the world as we now know it. And probably neither of those are true, but in understanding the system, you need to understand where it's coming from. 50 million people in the United States have no insurance. That number, rises and falls a little bit with the economy, but in general, it's a number that's growing as more and more people find insurance unaffordable. There is fragmented coverage and fragmented care built into our system. And there are insurance design gaps that have been introduced into our system over time, some of them for very good reasons, but they all serve to make it very hard for people when they're sick to get the care they need. That's the design of our insurance system. So the left and right of the political spectrum have solutions that they've proposed and introduced. And ACA, because of political compromise, is neither a purely left solution nor neither a purely right solution. It's somewhere probably left of center in the middle of that graphic. Design is building on the current system. So the goal is to create new marketplace exchanges. Patty will talk more about that in Utah, at least from a Utah perspective. There's also an attempt to reform the marketplace and to eliminate some of those insurance provisions that have been particularly difficult or troublesome for individuals trying to seek care. There are really kind of three separate coverage changes that are involved and part of the ACA system. So the first one is reforming the insurance markets. The second one is increasing responsibility to get coverage. Individuals are going to require to get coverage, and helping those who can't afford insurance. I want to just talk briefly about each of those. In reforming the insurance marketplace, under the ACA provisions, you can't refuse people with pre-existing conditions. That's true now for kids. That was sort of an immediate changeover, and now it's going to be phased in for adults in the coming year. You can't be dropped from your coverage just because you get sick under the provisions. There are no lifetime limits on benefits. There are no annual limits on benefits beginning next year. Government oversight of the premium rates and how the dollars are spent has increased in a significant way. In the past, that was all left to state governments under the insurance departments of individual states, and now the federal government is asserting some control over that. In the individual responsibility leg of this stool, everyone has to have insurance beginning in 2014. Now the actual penalties for not doing that are enforced by the IRS. They're fairly modest, probably not enough to actually, if somebody was forced with the choice of saying I'm going to get insurance or I'm going to pay the penalty would always be cheaper than the insurance. But nonetheless, that principle is being introduced that you need to have everybody in the system for an insurance system to work the way it's designed to, that is, to spread risk across a population. You need the whole population involved. And then there are state exchanges, and again, I'm not going to really dwell on that because I think you'll get a dose of that, other than to say there is a huge investment going on. This graphic is old, and I elected not to go find the current data, but $1 billion as of this point, I think now maybe much more, but is being spent to build exchanges in individual states and or for the federal government to go in and build and operate an exchange in anticipation of that beginning next year in each state. The third leg of the stool is helping those who can't get insurance. And so Medicaid is being expanded under the ACA to reach a broader segment of the population. The big provision that the Supreme Court decision affects is the Medicaid expansion. Under the federal law now, as interpreted by the Supreme Court, states don't have to do the Medicaid expansion. They're not required to do it. And so individual states are making this decision, and you can see that debate going on in Utah. You can see it around the country. Some of that's political, and some of it is economic. Saying no to Medicaid expansion means that a large segment of your population in your state is not benefiting from things that others potentially are in other states, and importantly, providers in your communities are not getting the benefit of that, and so they're putting political pressure on the states to consider Medicaid expansion, even if it's politically not a popular idea in the state. Additionally, there are subsidies to be paid to help for people who can't afford to buy insurance to be able to do so. So the law calls for the introduction of these subsidies for people living at up to 400% of the federal poverty level, and that's a level that takes you well into the middle class. So many people will qualify for these subsidies in order to make health insurance more affordable for them. Now, I don't want my talk here. I was trying to give you a perspective on the way ACA is written and the way it's being perceived and implemented by the administration. This is not meant to be a, do I think there are, it's not a Pollyannish picture. There are huge problems with that. Anytime you're disrupting and changing a system, you're introducing unintended consequences and new problems that are very difficult, and some of them feel quite intractable for implementers right now. But that's the goal. The goal is to find some balance to address the cost of the insurance problems in our system. We have a second problem in our system that is less known and less visible unless you work in healthcare, but I would argue is far greater problem in describing the challenge we have now with cost and quality results in our healthcare system. Our current system offers payment on a fee-for-service basis. Whatever I do, I get paid some amount for, and the way that payers or government try to manage that is they limit what they pay for those services you provide. They do it by setting a fee, a global fee, or sometimes they do it by discounting the price. Whatever you say your price is, I'm going to pay you, in some cases 10-15% of what your actual price is, because that's how we've managed to keep costs down, or we've attempted to keep costs down over time. But it doesn't address the fundamental problem that the system rewards volume of services, not value or outcome, the quality of those services. And changing that has been understood for 2 decades by, I think, the policy experts, by the general healthcare environment for the last decade as a critical step to getting to a better healthcare system. But it's very difficult to change because there's huge legacy investments involved in the old system, and because the economics of change don't really support the change during the period. I think you can thrive under a new payment system, but until there is sort of sufficient pressure to do that, providers in general in America do very well, and so they're not feeling economic pressure to change in a fundamental way, the way the nation as a whole needs them to feel that, or needs all of us to feel that. So the other thing it does that makes it difficult is it redistributes resources, and so some providers in the current system do better than other providers, and any redesign of the payment system would likely redistribute that wealth. Even if you didn't take a single dollar out of the system, some would go to different providers than others. And power systems, the people who are in power don't really want to see that happen. So I'm going to try to move us along here because of our time windows, but I want to start by talking about what we do to change the payment system. So we need to first focus on how do we change to improve patient care as opposed to how do we limit, because that's the current mindset of many people trying to change the system is, what do I limit? Current system rewards bad outcomes and not better health. That's a feature of how it was. Nobody intended it to do that. I don't think anybody set out to create a system that rewards you for doing bad things. But in healthcare, unlike virtually any other industry, if I go in and I make a mistake in your surgical procedure, in general, I get paid more money to fix my mistake when I go back to fix it, and there's some changes to the law recently that are designed to limit that kind of behavior, but in general, the system still does that, and further, it makes it really hard for me to do the right thing. If I design a system that reduces costs, prevents hospitalizations, if I'm a hospital system, at some point the CEO of my hospital is going to come in, CFO is going to come in and say, you know, this program you just invented that saves money actually maybe saves lives, and it may save somebody money, but it doesn't save the hospital money. It costs us tens of $millions in all those heart failure admissions that we used to get that we're not getting now because people's heart failure is being managed better. And so the system is set up to reinforce the current behaviors, and we need to eliminate that. There are lots of ways you can address it, and healthcare is working on a few. One of these is episode-based payment. Episode-based payment means we're trying to go from fee-for-service to saying we're going to pay in a bundle for all the care associated with a single procedure or a single service, and combine the payments of that. I won't go into some of these examples, but that's being done in a number of places. It has weaknesses to it. It doesn't actually prevent people. The primary weakness of episode-based payment is doesn't actually control or try to manage the number of episodes. So one way I can maximize performance is I can do the episode very efficiently, but then because as providers I tend to be in the driver's seat for how many of a particular procedure is performed, we just do more of those. We do them efficiently, but we do them too many of them that need to be done. So comprehensive payment is the broader based solution to this, and this is an attempt to pull together all of the resources for a given population or patient and pay on a total care based on the health. So we won't go into definitions of how you do that. You can get the slides if you want to do that, but in the federal government they're working on that. This is, many of us who've been around for a while lived through the capitation days of managed care in the 90s. This is designed to be different because there are different features of our healthcare system that are truly operating today that make it possible for us to have better information in making sure that the focus of a capitation or a comprehensive care payment is on population health rather than risk avoidance, which became the primary strategy used in the early 1990s. So the key, from my vantage point, and moving forward, is really we have to focus upstream on the health of a population. The longer we can keep people healthy, the more focused we can get on that, the better likelihood we're going to have of having the ability to serve our population over time as we age without breaking the bank for the federal government. Mike Leavitt, who is the former governor of Utah, former Secretary of Health and Human Services at the federal government, is fond of describing the overall picture of we're facing the problem that we as an American people want to be compassionate and we want to solve problems in a compassionate way, with running headlong into the problem of global economic dispassion, is what he calls it. The environment we're in, it will make it increasingly impossible for us to continue to operate in this space where America spends 16, soon 18, 20, 22% of our GDP on healthcare. That will make us economically unviable in relation to the global economy. So I'd like to just quickly close in the payment reform section by just saying in a nutshell, this next set of slides, which I won't spend a lot of time on, is really about what are we doing to deal with the problem of our population health. So we tend to think in America of healthcare as the answer to poor health. And if there's anything you could take away from this section, for me it would be understand this graphic, this pie chart. Our analysts would probably be frustrated that I'm even using a pie chart. They don't like those. They think they're poor ways of displaying data. But this pie chart purpose is to serve to point out that healthcare is the green pie slice there. If we talk about what contributes to premature death of an individual, the quality of our health care or all of the interventions we do to prevent death in the healthcare system only have 10% to do with whether a person lives a shorter life than they might otherwise have lived absent that. The far greater implications are in things outside of healthcare. So our genetic predisposition, the blue slice, whatever our genetics are, they are what they are. None of us control them. They came to us, they're there, but they have a big say in this. Our behavioral patterns, bigger say, what we choose to do, how healthy we live, what we eat, what kind of exercise we get, are a far bigger driver of that than healthcare, anything the healthcare system can do. And even a larger driver than healthcare are the social circumstances we are born in, we live in, we make for ourselves through our choices about economic advancement and the society around us, what we do to take care of a population of people. So we're not going to really be able to solve the healthcare cost problem by just thinking of it as a healthcare problem at all. It's really a health issue. It's really about how we engage that. Another way of thinking about this particular problem is to think about, this slide's meant to describe, there are 525,600 minutes in a year. If I'm a diabetic patient and I am properly being cared for according to the guidelines that are out there, I'm going to get 4 visits with my primary care doctor a year. Every quarter I'm going to get in, I'm going to have my A1C tested, I'm going to have a series of things done. So I'm going to have face time as a doctor with that patient for 1 hour versus their life, which is 525,540 other minutes that they're not in front of me as their doctor. And that means there are lots of other more powerful forces driving my behavior than what my doctor tells me I need to do to manage my health. So again, I have more time to do, so I just want to highlight a couple of things in this space. One is, in the way we build our insurance system, there are many people, in the current insurance system, there are many people who have no incentive to engage in making wise choices. So when we as consumers participate in the system, I want to just walk you through a quick example. So if I'm trying to cause some decision about where I should get my knee replacement surgery, we've got on this graphic 3 prices, and these are real prices. That this kind of variation would be very common in the healthcare system. This is what it costs to get the care from provider 1, provider 2, or provider 3. Now, I can tell you with confidence that in any marketplace in the United States of America, I could find these 3 examples and I could pull together all of the quality data, and I might be able to demonstrate at least that these are equivalent. I could probably show you that price 1 might be better care for other reasons, but let's just assume that for a minute. But in that case, if the insurance plan is built with a $1,000 copayment, my knowledge of the system goes against the average belief system of the people. They believe, in general, American people believe, if you ask them about this and you put 2 prices in front of them for health care, the one that costs more is better. They always believe that, overwhelmingly in the data. And so if I have a $1,000 copayment in my health plan, I've effectively incented the person to choose, well, I should go with the most expensive one because it's going to cost me $1,000 either way. If I have a 10% co-insurance structure, another common model in our insurance system of consumer engagement, same outcome with a $2,000 maximum, because when they build those at maximum out of pockets, which are important to protect consumers, effectively I'm capped at that level. Big surgery like this, either way I do it, my costs are the same. I'm incented to choose the most expensive option, therefore encouraging prices to go up. High deductible health plan. Just by a show of hands, would you tell me, how many of you have a high deductible health plan now? Several of you. So that's increasingly common. It's pretty much, in this market, I think has become a commonplace, and it's being sold broadly around the country. Under that model, still, because of the price of this is a high cost elective procedure, the incentives still drive people to that third one. So the only model in this case that really works to incent people to choose the lower cost provider is what's called a reference pricing model. This is rarely done, but being done now mostly by some very large employers, self-funded employers who are more sensitive to this and are trying to find ways to get ahead of the insurance curve. But in reference pricing, what would happen is there would be some attempt to determine providers of equal quality and then to say we will pay the full cost of the low-cost provider in our healthcare system. And then if you want to go to a more expensive provider, you're welcome to do that, but you're going to pay the difference. You'll pay all of the difference. Doesn't matter whether it's so you'll get zero cost for the low cost, and you'll get up to $10,000 out of pocket if you want to go to the one who's charging $10,000 more in this example. More and more that kind of work is going to creep into our system because payers are coming to understand that they alone can't affect this by working on providers and on their relationships through the system, that we as consumers need to be engaged in our health care at the other end. So I am out of time, and I've stopped looking at Stephanie because I know she'll tell me I'm out of time. But I'm now into my cushion for questions. I just want to finish by talking for a little bit about delivery design and redesign of that. The system we work within is really designed around providers and not patients. So the people who use the system are at the bottom rung. It's a very inefficient system. It's very fragmented. I am caring right now for an elderly parent, and I know this healthcare system very well. I've worked in it for 20 years, and I am surprised every day at how hard it is to coordinate care for my father. And I think, well, what if I didn't know this system? How much harder would it be? And what I've come to understand is that's a system property. It's built into how we've designed our healthcare system. The last element I'd like to just have you understand about our system design is our system is the best in the world at recovery. So if you need to see an interventional cardiologist for open heart surgery or some other major procedure, there is ample evidence that the best care you're going to get in the world will be found in the United States of America. That's absolutely true, and I think, and we should be proud of that. I think that's done a lot to extend life, to make quality of life better for a lot of people. But if we're trying to prevent disease or manage disease to prevent the need for that recovery, we are far from the best in the world. We end up spending more on recovery because we figure we're good at it, and it's what we've designed our system around. So more people end up needing those things, and we do them well, but we don't do them intentionally. So I won't have time to talk about this except to say the third leg, or the third sprocket in the gear analogy in the ACA is a significant investment by the federal government in trying to promote redesign of our healthcare system. So the ACA has a $10 billion fund, $1 billion a year for 10 years, to be spent on experiments and implementation of the best of those experiments nationwide in redesign of our healthcare payment system and our healthcare delivery system. The Beacon project would have been a precursor, but in that same principle. So this project we're now talking about is a redesigned test funded by earlier legislation, but those kinds of tests are going on across the country, and we're participating in some of them. Many providers in our community and payer systems and the state government itself are participating in these kinds of redesign efforts at the community level. So I'm going to skip ahead and just say, let me just end with where we began. Our healthcare system is perfectly designed to get the results it now gets. And the main quality improvement principle that we would like to apply and have everybody come away thinking about healthcare in Utah is, if we want it to produce something else, we have to design it differently, because the system will produce results that are consistent with and related to the design of the system that we've developed. And our system produces what it produces because of the way we designed it. So the efforts of Beacon, the efforts of groups like HealthInsight in general, the efforts of the state innovation models activity that the state government is running, the efforts of health insurance exchange, these are all about redesigning our system to produce a different result, giving us some likelihood of getting where we need to go as a nation. I appreciate your time, and I'd like to now, I have, I think, 7 or 8 minutes for questions about this. So, anybody have a question? Yes.
One of the things that I am starting to see at a very beginning level is consequences of some of the new rules that I don't know if that was expected. I have a specific example. I know that the Deseret Industries system has employed people that are hard to employ on a full-time basis, and for many of them it's like their only source of income.
Mm-hmm.
Now that there's a requirement that employers offer medical insurance to anyone working 30 or more hours a week, they're cutting all of that whole population back to 28 or fewer hours a week, or a week.
Yeah.
So that, in my mind, that's not a conflict, that's not allowing a very good thing to happen in the future because of this new rule. And it kind of makes me worry how many of those other kinds of scenarios are out there, and is there been any thought to that?
Well, I think, yes, there will. My view is the ACA law was written in the space of Washington, D.C. by some people who were really smart, and some input from the field in the early days, but it became at some point a political process, and in fact, if the history of how that law got passed, it got very political. They passed a version of it that wasn't even supposed to be the finished version, but it was the only one they thought they could. They had it through the House, and they had to get it through the Senate, and that's what they pursued. What I would describe, I think every time you make a major change in a system, unintended consequences emerge, and some of those maybe were anticipated, most of them were not. I'm sure nobody in Washington was thinking, our plan here is to make it hard for an organization like Deseret Industries to help people out of their circumstances by teaching them new job skills and to lower that. That was never an intention. What they were trying to address by requiring that was the broad brush principle that you need to have everybody in the system in order to really have a functioning, community-rated healthcare system that's going to spread cost in an appropriate way. And I think there's a problem with that inherently, and one of the problems is you cannot anticipate the creativity of people who are trying to respond to regulatory solutions. And no matter what you do, people will find some way to turn that to their their advantage, some group of that. So the overregulation tendency is just a failed model in general, I think, but it is kind of what they were trying to solve with that. And as I look at it, I think it's really hard to tell today how many of those examples are going to pan out as major failures in the system. There's this debate in the national discussion about how far off the federal assessment of the cost of ACA was. So in theory, because of the cost offsets and the number of people in the system and the kind of new taxes or other things, in theory, over 10 years, ACA was supposed to save $100 billion. That was the theory at the time it passed and the basis under which it was passed. The discussions now, because of those unintended consequences and because of how the market has responded differently than the Congressional Budget Office anticipated, the theories, you know, it's really a debate not about whether it's going to save money, but the theorists are debating about how big the increase is going to be tied to ACA. So it went from minus 100 billion to plus X, and I'm not an economist, and I wouldn't predict the outcome of that. But I think some of those will turn out to be political gamesmanship, and some of them will be real, and there will be real costs added and real people hurt by this change. The question is, will more people be benefited than are hurt in the long run, or will we stay the course long enough, or will the pressure mount and additional changes be made? It'd be nice if the environment were such that some of these unintended consequences that nobody wants to have people hurt in those cases could be negotiated into changes in the law that would allow those kinds of exceptions or those kinds of fixes. But that's a pretty tough environment, and there are very few of those happening. There have been a few already that have actually been fixed, but they have to be attached to a bill that's unrelated to this, because anything that's associated with this, you know, I heard in the news this morning that the House once again passed that we're going to repeal ACA. So that's a political move. It has no meaning, it has no bearing on the reality of the law, but it is, and I think they've done it, I don't know, 37 times. So it's so it's not relevant, and so that's not the vehicle by which one could actually make these improvements. So any improvement to the law would have to be made in a sort of attached to a bill that has to move for another reason and be broadly supported by both sides. And there are lots of things that would fit that category, but the political environment makes it likely that most of them will linger out there, and there will be people harmed by the changes that are implemented. So, yes? Okay. So, I don't think it can get worse very long, because I guess the way I'd put it is there are some subspecialties in medicine who can afford to say, I'm not going to see Medicare patients and I can still make a living. It's very few and far between. If you think about that number, I showed that slide about the total picture. Between Medicare and Medicaid and the CHIP program, if Medicaid is expanded in a given state, say to its maximum in a general, as the total dollar spend in a given community, I would say it's approaching 60 to 65%. So if you say, I'm not going to see Medicare and Medicaid patients, you've limited your ability to actually make a living in the business. Now, there are some people who choose that. They choose it for either frustration or ethical reasons. I'm tired of this. There's some people who are blustering about it as a positioning, and so, you know, determining the two. But in the end, I personally don't believe you can actually survive as a provider long run if you choose to say, I'm walking away from that system. So.
They do that because the payment mechanism, the payment system is inefficient, and they're not getting, rumors I've heard, they're not getting paid by Medicare, and so they're saying, why should I?
Well, so it's a pretty complicated, nuanced argument. I believe that there's great inefficiency in our healthcare system. Now, Medicare more than Medicaid, most of all, Medicare second most, is a significant. They take significant steep discounts off of price. So if I'm a provider and I say my price for performing this procedure is $200, Medicare might pay $30 or $40 or $50 for that. Now, so if the provider's accounting system treats that, they're absolutely taking an accounting loss on it. The question for me is, could you provide that for that price, and how much of that is tied to, I really can't do this service without losing money, my fixed costs are higher than that, versus how much of it is, I haven't figured out a way to do it. The problem Medicare has is they've been driving that, you know, that's the only way up to now they've had to cut costs, is we'll just take a larger and larger chunk out of what we'll pay, a lower, steeper and steeper discount. And then on top of that, they add heavy regulatory burden. So if I'm a a solo practitioner or somebody who doesn't have a big system to be able to manage the regulation burden, taking Medicare is increasingly difficult because I'm expected to comply with all these rules that you can do at scale, but in a small office it's pretty tough to do. So I think that's part of the problem, but the solution is in that sort of comprehensive care payment. If we can get more of those in place, these ACOs that are being introduced through the legislation that are basically population management strategies, you can make money even at the Medicare rates, but you will have to change how you do business. And it's in that space between transitioning from the old to the new where some providers are feeling very pinched by it, and some will go away. They won't be able to survive in that. And you know, this is another one of those unintended consequences. We have not enough providers for the burgeoning population, particularly the aging population. So more and more people, baby boomers, are aging into Medicare at the same time as we're putting more and more of a squeeze on that program. And so providers, some of them in a reactionary way, some of them in a, you know, a more thoughtful way, are saying, I can't cope with this system and I'm going to respond in the way I think I have power, which is my market power is to say I'm not going to treat patients. I don't think that'll work, but I believe many will try it, and I believe there'll be some pain in this transition. But it's a transition that absolutely has to happen. One more question, and then I'll...
If we could make it quick.
Okay.
We could go on all
Yep.
day, and
Yep.
Marc is so knowledgeable, and I love
So-
listening to him, but go ahead.
Okay.
Okay, Patty's going to relinquish some time here, so that's good. Go ahead.
Real quick, you've very effectively laid out the need for system redesign. So given this audience here, has that translated into an increased demand for project management professionals to get involved in that system redesign? Have you seen that at your level?
Yes, well, I mean, I think absolutely in the marketplace, there is this tremendous need for people who can help you figure out how to get from where you are to where you need to be in design. And so that's not a skill that's taught in really even in hospital management or in healthcare management programs. It's really not taught very well. It's certainly not taught in the professions. So doctors don't learn how to do that. Nurses don't learn how to do that. Other healthcare professionals don't learn that. And so we struggle with that. And so any skill that can be brought from the broader community is very useful. At HealthInsight, we rarely hire based on anything other than ability, innate or training that allows someone to be an effective manager of a process. And so we teach process management as sort of, I think, our core skill that we're recruiting for. Even people we hire as analysts so often become managers of process redesign. That's just kind of what we have to do if we're going to be successful. And I think that's broadly true for providers in the system. And so there is a great need here and a great opportunity. So, thank you.